This is SG2 Perspectives, a conversation with SG2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
What this model is solving is for that immediate need for care. Because what's been happening over the last many decades is these people either stay at home, tough it out, get worse, wait for that appointment, or they end up going to the ED and waiting many hours and being roomed together with trauma, with heart attacks, with stroke. Those solutions are not great solutions. It's a solution for the fact that mental health system is overstretched, and we created an extra door where people can get access today.
Welcome to SG2 Perspectives. I am your host, Trevor DaRin, and I have two new and exciting guests with me today, Dr. Erick Macias and Matt Mindrup, both from SSM Health in St. Louis, Missouri, to talk about the behavioral health urgent care that they recently implemented, but long enough that they have a little bit of a story to tell and some background. I haven't heard of that before, and so I'm so excited to hear from them, the origin story and how it's going and what problem it's solving. Dr. Macias and Matt, thank you so much for joining. Matt, I'll go to you first. What's behavioral health urgent care? How did you guys come up with this idea? What does it really mean and do for your community?
Yeah, Trevor, the behavioral health urgent care was a conversation that developed when we looked at what gaps in care do we have in our traditional care models, being part of a pretty large behavioral health platform here. We sought to create a centralized approach in which individuals in mental health crisis, substance use crisis, could receive immediate comprehensive support without relying on emergency departments. Not unique to St. Louis, most patients don't have that level of care from a mental health perspective, and therefore they flood the EDs and things of that nature, which is not great for the patients. We met with a bunch of community collaboratives, community mental health agencies to look at designing a care model that is comprehensive, quick, and supports the needs of the St. Louis market. Through that approach, we organized everyone together, discussed what those gaps could be, access, mental health support, medications, connections to care. And based on those ideas, those collaborations, we're able to come up with the behavioral health urgent care, which is a unique model. The behavioral health urgent care operates as a walk-in basis. It's a walk-in clinic, operates Monday through Saturday from 9 a.m. to 7 p.m. So if a patient presents during that time, you're going to be seen. We focus all of our attention to ensure there's very little barriers to treatment. For instance, we don't do co-pays, we don't have insurance, we're still able to see you. We don't want any sort of issues to prohibit you from coming to get seen. We treat patients aged 5 and above at our SSM DePaul location, which is the first in the region that we opened up the behavioral health urgent care. A little bit about the staffing model. This is what is unique about our operation. We entered into a really good partnership with BJC Behavioral Health. They provide some of the staffing models at our behavioral health urgent care. They do some intake work, some registration, and they do all of our discharge planning as well. We also staff that urgent care with nurses and psychiatric nurse practitioners. When a patient presents, we're able to meet the total care needs of those patients. When we looked at creating this, we didn't want to create another access point. We wanted to use the unique and highly specialized skill sets that we have from each of our agencies. Our psych NPs, with collaborations with their psychiatrists, are great at treating the medical and medication needs of these patients. The discharge plan, which is really where a lot of our gaps in care exist, is connections to care. Well, that's why we brought in the experts in BGC Behavioral Health for that area where DePaul is, to reduce all those barriers that exist, and we schedule those patients with their next levels of care. Our nurses are highly specialized in behavioral health and bring a unique acumen to that space. The patient flow is different than what maybe some of you all are thinking about an urgent care medical model. A patient can present walk-in clinic, and they're going to be met with our registration staff. We're going to register you based on what all information you have available to us, and then we're going to open you up in our electronic health system. And then we're going to room the patient. So it's similar to what you would see in an urgent care. We have 6 rooms at this location. They're highly unique in that they are specialized to treat significant and persistent mental illness, high acuity, but also offers a visual picture that it's an open and inviting space. space. So it's not institutionalization, things of that nature. You're then going to be met with our nurses first. They're going to do a triaging to understand what's going on, what areas can we help treat you. Based on that, the nurse then staffs that case with the on-site nurse practitioner and our intake specialist from BJC Behavioral Health. We're going to discuss, do we need to do a full psychiatric evaluation for potential admission to a higher level of care? Is it a medication need? Things of that nature. That'll depend on who you actually see next. We do prescribe meds. We administer meds at this site, which is great. And then the most innovative part of this urgent care is what happens next, which is the discharge process. We met and collaborated with a lot of unique individuals and partnerships in the St. Louis market. We didn't want to hand Mindrup the patient here and say, hey, call Dr. X and hopefully you get in the next 3 to 6 months. That's not a care model that's going to work. What we ask the community agencies to do is, can we get some preferred or next day urgent appointments where we can schedule these patients priority wise at their agencies, with the focus on the most vulnerable and underinsured population that we have. And that's where the expertise comes in with the discharge planners, is to uniquely tailor that care discharge plan to those patients. And that is essentially the high level overview of what we do in that space. The average amount of time a patient can spend in that is about 90 minutes. So we try to make it pretty quick and unique to that patient's individual needs.
This is so exciting. Thanks for giving those details. I want to hear more. Dr. Macias, can you give us a little more of the genesis story? What were the existing problems that this was hoping to solve? Obviously, it's a great access option for this set of patients, but I can see a lot of connected problems this was probably helping with as well.
As a psychiatrist, I get calls every week for people saying, I'm depressed. When can you guys see me? And the most frustrating and painful experience for us as clinicians is to say, we're full, we're not taking new patients, we don't take your insurance, or we can see you in 3 months. That is really frustrating for all of us in mental health care or behavioral health care. And I'm sure that people out there will feel that anybody in my position would have very similar stories. What I tell people, imagine if you're having a toothache and you call your dentist. The dentist says, I will see you in 2 months. That doesn't work. The same is true for mental health. If you're having an anxiety crisis, if you're having a panic attack, if you're having a psychotic break, if you're having suicidal thoughts, you need to be seen today. What this model is solving is for that immediate need for care. Because what's been happening over the last many decades is these people either stay at home, tough it out, get worse, wait for that appointment, or they end up going to the ED and waiting many hours and being roomed together with trauma, with heart attacks, with stroke. Those solutions are not great solutions. What this is trying to solve is not only access, but immediate access to support and treatment and to an appointment that will follow up with the issue. It's a solution for the fact that mental health system is overstretched, and we created an extra door where people can get access today.
Dr. Macias was saying before the behavioral health urgent care really existed, the only model was the emergency departments. And when you're conjoining with other folks that have higher acuity issues that are non-behavioral health, we look to replicate an area similar to an ED, but more inviting space with all the experts to totally treat that patient. Because if Matt is seen in an ED, I may have access to the psychiatry team eventually after I can get seen in a couple hours, whatever it might be. But then they don't have the discharge planners there to help ensure Matt gets connected. There's gaps in cares in that care model. And here, the genesis is that we have everybody that can totally treat the needs of that patient in one space, all dedicated to highly specialized mental health care.
Matt, give me some numbers. How many patients are you able to see? How many patients still or providers don't know this is an option and behavioral health patients still show up in the ED? Give me a sense of the scale.
In the first year, this program opened up in late August of 2020. It was the first of its kind in the St. Louis market and one of the first ones around the country to operate this sort of model. We saw 750 patients between September and December of that year, which was pretty substantial. The following year, we saw about 3,500, and we've seen 4,000 plus each year. We are unique in that some of the other crisis centers for behavioral health around the state operate on a 24/7 basis. We are unique in that we operate on an urgent care model. So we open and we close, and our volume is still very high. The third busiest behavioral health access point in the state of Missouri. We're located very close. We're on site of DePaul Hospital, but on the other side of the hospital from the ED. What's interesting to also note is when you look at ED, so the emergency department data for behavioral health patients, the numbers have actually increased We had thought that ultimately by operating this model that we would pull volume from the ED. And while that has been true, it also speaks to that this opened up right at the beginning phases of COVID, and all of the patients that have really had the mental health crisis with that have also still been going to the emergency department and the urgent care as well. So while the ED rates for behavioral health patients are increasing, it would be unsustainable if this model wasn't there currently, because we'd ultimately see 3,500 more patients in those EDs each year that could be seen in our space. Another piece here is we can bridge medications. It's one of the hallmarks of what we do. Like Dr. Macias was saying, if they plan for you to see Dr. Smith, psychiatrist, and you can't get in for 2 months, you can come back to the behavioral health urgent care and we'll see you again and we'll bridge that medication so you can get to Dr. Smith. We want patients to be gainfully employed with their psychiatrist and their team and not have to rely on the behavioral health urgent care from an outpatient clinic perspective. But we do offer that bridge model to help ensure that the patient gets the care they need as well. Outside of just volume metrics in of itself, we're certified by the Department of Mental Health as a behavioral health crisis center. We operate on regulations that are specific to behavioral health needs, and it's a great collaboration that we have with them. They did an independent report with the Missouri Behavioral Health Council that I want to highlight because it's got a lot of great data for us that we were able to get just last year. This is specific to 2024 data. We saw a little over 3,500 patients that visited that urgent care. The financial impact in hospital diversions was estimated to be just under $45 million. That's a big number, the 45.7 million to be exact. What the Department of Mental Health used to gauge that number is a cost savings model done by Wichita State University that estimated the cost of operating a behavioral health crisis center in that market. And then the Missouri Behavioral Health Council adjusted Missouri specific numbers and estimates for hospitalization costs, jail diversion, law enforcement salaries, and sort of operations of the crisis center, all included in that. And they did estimate that about 98% of our patients that presented to the behavioral health urgent care likely would have went to the emergency department to seek care if that was not open. A little bit about the medications we treat. About 70% of the medications we treat with in that urgent care are typically anxiety and mood stabilizers. And about 15% are antipsychotics, which we have the ability to treat psychosis, things of that nature. Then a little bit of the substance use medications as well. The highest age range that we see in this space is ages 18 to 29, which makes up about 32% of the patients we see. And then we have about 19% of our patients that are seen are actually child and adolescents, which is a pretty high number. It's also important to note that when the DePaul urgent care opened, it was adults only, but we saw such a massive need for the adolescent mental health needs of our area that we made a pretty significant pivot within the first 2 months to open up to adolescents and pediatrics in that space as well.
When Matt talked about anxiety, lots of people in the audience may think benzodiazepines. It is important to know that we do not prescribe controlled substances because this is a patient that we just saw today. We try to address anxiety by means outside of controlled substances.
Dr. Macias, thanks for giving your background as a clinician and how much this helps from your perspective. Talk about some unexpected results of this model. Did this meet your expectations? What were maybe some surprises or gaps that are still persistent?
One of the biggest surprises for me as a psychiatrist is how hard it is to see a psychiatrist. I did not expect to see so many people coming because they cannot get a refill on their medications. It's heartbreaking to me that our system is so difficult to access that when one of us psychiatrists retire, sometimes there is no proper follow-up. And we see a lot of people that come just because they cannot get a refill, either because they moved to the new city and the next appointment is 6 months and they run out of medications in a month to their psychiatrist retired or left practice and they are in need of a refill. To me, that was heartbreaking. The second surprise to me was it was difficult to convince my inpatient team to accept patients admitted from the urgent care because they are so used to admitting people from the emergency department. To take care of some of their concerns, we created a way to get labs, to get EKGs on the urgent care, just to make sure they feel comfortable accepting patients for a direct admission from urgent care to the inpatient unit. To me, that's another big win, was to allow patients to bypass the ED if they needed admission. It's a surprising finding that we learned as we did this process.
The medication piece, I think, is not something that we had originally thought would be that high. That's a significant part. It's over 50% of the patients that we see are just needing the bridge medications. We were surprised that we'd have to have Matt Mindrup, the patient, present 2, 3, 4 times before he would get in to see Dr. Smith if that was his preferred treatment. And we've accepted those patients each time we do a full behavioral health workup, things of that nature. I'll double down a little bit on the quick pivot we had to make with the pediatrics. The child and adolescents was not something that we were planning to do that fast, but the need in our emergency departments in our area specific to the COVID crisis, which hit that population very hard from a mental health perspective, forced us in a positive way to open up and move things a little quicker for treating pediatrics in that patient population as well. Those are the big things that stick out as unexpected results and gaps in the care.
Matt, this model's really exciting. I hope you're thinking about expanding it to other sites. And if so, what lessons learned? What might you do different? Are you thinking about geographies, patient populations, et cetera, differently because of what you learned?
We actually already have replicated this at St. Louis University with a partnership with Places for People in the city health department. A couple of things immediately come to mind for like lessons learned or what we ended up pivoting to and changing for the new site is we opened up before there was any behavioral health crisis center regulations. We just built the model and the regulations came afterward about how do we structure this with Department of Mental Health funds and things of that nature. A position comes to mind that we didn't have at the onset of the DePaul urgent care, which is a peer support specialist. Essentially, that person helps connect the patient with the discharge resources. DePaul is really good about treating and connecting patients, but we also need to have a little bit more of a presence outside of the walls to ensure that Matt Mindrup can get to his next level of care. The addition of a peer support specialist was vital that at both locations, but that person ultimately follows up with these patients after they leave to ensure that there's no breakdown in transportation or other barriers that might exist for Matt getting to his appointment. And if there is, that person deploys to the community to actually pick up Matt Mindrup and take Matt to his appointment and he'll take him back home. If patient consents to that, we're able to do that. So it's really looking at treating the patient while they're here, but also once they leave and they discharge, they're back in the environment potentially that caused some of that undue stress, things of that nature. So how can we make an impact outside of the walls a little better as well? That was a big piece of what we changed for both sites. We looked at the integration of other programs that might serve well in the physical space as well. So we also operate a couple of long-acting injection clinics, which are awesome programs that help patients that are on antipsychotic medications, substance use medications, not have to have daily medicine. These are monthly injections or even more often than that. We actually co-joined the LAI clinic at St. Louis University in the same physical space. And why do we do that? Well, now we have a pharmacist in the space that can help the psych NPs say, hey, what medication would you recommend for this? That's the access that we have with pharmacy on the site in the space at SLU, which we don't have at DePaul currently, but looking at ways that we could do that. So even getting more specialized care to help ensure that the medications we're selecting for these, that the NPs and the psychiatrists have an idea to bounce off for medication with the pharmacists in the space as well. A couple other things that we're working on, Trevor, the ideas of behavioral health crisis centers, a lot of people don't know that we exist still, or they're trying to understand what we do. We've been working with our emergency medicine EMS liaisons all around the state of Missouri. We are open to treat urgent mental health crises. We know that about 60% of the patients that present to EDs for behavioral health needs don't get admitted. Logic would say that maybe a subset of those patients would be best served in the urgent cares. So we're really working outside of the walls here to ensure awareness and to get patients to present to the right location to get that right level of care.
There is the issue of EMS and where they can drop patients off. By regulations, they have to take them to the emergency departments, but we are working to make sure they are also allowed to make a judgment call. And if the patient will be more suitable and better taken care of in the behavioral health urgent care, they can bring those patients directly to us.
And then just some other efficiencies that we've been looking at, process flow things, documentation, the movement of the patient. We've been able to streamline quite a bit, even at DePaul. We knew what it would look like here. This was all a vision and this was a creation, and we've learned quite a bit additionally from just workflows and making the patient experience as good as possible as well. Working on really keeping the visit as short as possible, but allows us to intervene appropriately with all those patients and even initiating with our discharge planners more crisis crisis intervention skills, not a clinical therapy session, but how can we give them some basic tools when they are having stress, whether that be financial, emotional, things of that nature, that they can work through that so they don't decompensate anymore after they leave here as well. And then really just the big piece, Trevor, as anywhere around the country, continuing to dive in, how can we best support social determinants of health? It's a chronic issue that plagues everybody, and we want to ensure that we got resources for all of those social determinants for our patients. We have a saying here at SSM that nutrition is mental health care. So how we ensure that our discharge planners are so connected in these areas that the patients can get the wraparound services they need.
Matt and Dr. Macias, thanks so much for sharing this story. Too many negative news stories right now. This is a pretty exciting, optimistic, positive story. Thanks for doing this work first, and thanks for sharing the story with our audience.
Good talking to you.
Thank you.
Look forward to having you back on SG2 Perspectives again soon. Excited to hear what you do next. Thanks for listening. If you like this episode, please subscribe, rate, and review us, and/or follow us on Twitter and LinkedIn at SG2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.